Good day. My name is Imelda Williams. I'm going to give you feedback on the formative test 1 and starting off with the first questions, and these are multiple choice questions, so each one is marked as equal 1 mark. So the first question was a normal bolus angle measures between, and the correct answer for that one is that it measures between 20 to 40 degrees. The next question was one where I added an image, so match the best description to the arrow structure as seen in the image below. And the correct answer for that one, of course, is the osperonium. In question 3, Carlos disease is a vascular necrosis, and it is a vascular necrosis of the navicular bone. And then for question 4, choose from the options below the test to determine ankle ligamentous instability, and the test for that one is the posterior draw test. It's also called the posterior draw sign as well. And then for question 5, a pylon fracture affects the, and it is the tibial plafond and the distal tibia. So it's tibial plafond and the distal tibia. And then question 6, the Ottawa knee includes the following criteria, and the correct answer is isolated patellar tenderness. If you look at the other options, can't be the tenderness of the head, it should be the tenderness of head of the fibula. In terms of the age, should be 55 and over, and inability to extend, it should be inability to flex. So I think that was the 6. 7. 7 was also a multiple choice question. Isogon fracture is, and of course the answer there is an avulsion fracture of the lateral tibial plateau. Okay, so that is the end of the multiple choice questions. We're now going to go to the scenario questions. And the first scenario is a patient who fell off a bike and now has a very painful and swollen ankle. And it's clear that this patient had a serious injury to the ankle. We've got an avulsion of the medial malleolus. And then we also have a spiral fracture of the distal fibula, and there's also medial talar shift as well. So your overall comment should be, there is an avulsion fracture of the medial malleolus of the left ankle, as well as a spiral fracture of the lateral malleolus, the lateral and distal fibula, and there is also medial talar shift. So just to remember with these scenarios that the cases are marked out of 3. So when you write your comments down, ensure that you have at least 3 facts to support your opinion. Okay, the next case is a patient who was in a car accident and is now unable to weight bear on the right foot. Okay, so if we look at the big toe, we can see that there is, and you can see that especially on the oblique view, that there is a comminuted fracture. It's also intra-articular of the base of the proximal phalanx of the big toe. And then when we look at our metatarsals, we can see that there is fracture dislocations of the metatarsal heads of the second till the fourth metatarsals. So overall, your comment should be there is a right big toe comminuted fracture at the base of the proximal phalanx, and this is intra-articular as well. And there are fracture dislocations of the heads of the metatarsals of the second to the fifth metatarsals. Okay, so for case 10, we have a pediatric patient who fell down the stairs twisting the left foot. So on this image, if we look at all of it, you can see that there is no evidence of any fractures, any dislocations. What we see at the base of the fifth metatarsal is, of course, a normal variant. It is an unfused apophysis at the base of the fifth metatarsal. The reason why this can be confidently identified as a normal variant is because it's well circumscribed and it's also in a vertical orientation. Normally, if it is a fracture at the base, then the pull will be more so that the fracture fragment lies more transverse and not in a vertical orientation. So to write your opinion on this case, then there's no fractures or dislocations noted. There's also no real soft tissue noted. And what you could add, there is a normal variant, which is an apophysis at the base of the fifth metatarsal. So the next case, which is scenario 4, this is a patient who had a skateboard injury. Okay, so it's quite clear that there is a fracture line because we see that lucent line. This is the epiphyseal plate and the lucent line is below the epiphysis, and that makes it a Salter-Harris type 3 fracture. You can also note on the lateral view that the Kagas fat pad is displaced. So overall on this patient, you can state that there is a Salter-Harris type 3 fracture of the tibia, of the left tibia. The Kagas fat pad is displaced, and you can also see the soft tissue swelling on the medial side of the ankle. However, there's no joint dislocations on this case. So for scenario 5, this patient did not have a history of trauma, however has a very painful knee. There's 3 images available to look at. So when we look at these, that looks like avulsion fractures. If you look very carefully, it's evident that they are well circumscribed. They're also sitting in the superior lateral corners of the patella, and that is where we normally have either our tripartite or bipartite patella. On the lateral view, we can see there is no lipohemarthrosis, so you're looking for a lucent line just above the patella, and you don't have that. And there's no other evidence of any fractures. And then on the skyline view, just see that this is a tripartite patella. So it's not a bipartite because we have got at least two partites, if I could say it like that, on this case. So your overall opinion for this case then is that there is no joint or bony abnormalities. This is a normal study with incidental finding of a normal variant, which is a tripartite patella. Scenario 6. We have a patient who fell and is unable to wait there on the left knee. You can see on the APV there's significant soft tissue swelling there. It looks quite dense there. However, if we look at the alignment of the condyles, the medial, femoral and tibial condyles line up, and also on the lateral side, the femoral and tibial condyles line up quite well. On this image, doesn't look like there's any fractures of the tibial plateau. However, on the lateral view, we can see that there is a fracture of the patella, and it's near the apex of the patella, and also there's quite clearly a lipohematosis and also quite a big effusion as well, so quite a lot of swelling of the knee. So overall, your opinion for this case is if you look at the fracture itself, it's the slight displacement in the loosened lines here, but it's very minimal. So there's minimal displacement of the distal pole of the patella with the fracture, and then there's also lipohematosis as well as joint effusion, and no other fractures or dislocations are noted. The final case that we have is a patient who was hit by a car whilst crossing the road, and then exclude fractures to the lower leg. Okay. So, of course, what we should remember with the lower leg is that it is a ring-like structure. So if there's significant fractures down in the distal parts of the lower leg, we should make sure that there is no fracture, in particular of the head of the fibula, and this looks quite normal on the available view. However, we can see that there are significant fractures, and if we just look at the tibia, we have got a displaced spiral fracture of the distal tibia, and this fracture line, if we look on the lateral view, it actually runs into the joint. And then there's also a fracture of the distal third of the fibula as well. So your overall comment for this case then, there is a displaced spiral fracture of the distal tibia which runs into the mortise joint, and there is an associated fracture of the distal third of the fibula. You could maybe add that there is no evidence of a fracture to the head of the fibula. Okay, so that is now the end of the cases that I gave you. As always, if you have got any questions, please feel free to contact me. Thank you.